Thanks, Josh. Before we start, I'd like everybody just to stand up and get a stretch. I'm seeing more and more people are moving to the back, and that's a sign we got to kind of get the blood flowing. So before I speak, let's just speak about something that's pretty, a little bit dark. I'd like you guys to kind of do a little stretch. All right. So I want to just introduce myself. For those of you who don't know me, I'm Stephen Greenberg. I have the honor and privilege of serving as the current APSF Vice President. Let's see here. Where is the advanced keyboard? Second. Okay. There are my disclosures. None of the investigator-initiated grants I'll be speaking about today. And here are my objectives. I'm going to define medical and medication errors, something we actually have not done yet today. I'm going to discuss the APSF's activity on medication errors, discuss the historical and global perspective of criminalization of medical error, and then describe the unintended consequences of criminalization of error, and discuss the APSF response on criminalization of error. So, what is a medical error? According to the Institute of Medicine, it's the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. Medication errors, according to WHO, any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of a healthcare professional, a patient, or even a consumer. So that's what we're talking about. And we've gone through this through the last several hours. Medication errors are one of the most common medical error. You know the cost. I think something that really strikes me is that 1 in every 20 perioperative anesthetics delivered can result in a medication error. How many of you are anesthesia professionals? Just raise your hand. Okay, that means at least once a day or every other day, we're seeing or we're actually involved with a medication error. That is just unacceptable. We have to make change. We know that substitution error is the most common error, and 4% of all anesthesia closed claims database are medication error related. We know, and you'll hear throughout this brief discussion, anesthesia departments should create a culture of no blame so that everybody can speak up against these patient safety threats. And I do believe barcode scanning has been shown to decrease medication errors. So, this is not new to the APSF or its newsletter. In fact, in 1987, 40 years ago nearly, the winter issue, and I quote, "Mother dies when given 2 ampules of adrenaline in mistake for Pitocin." That was in 1987. You just heard Mr. Lefebvre talk about an article we just published a few months back in the newsletter, mistake when giving TXA in the subarachnoid space when it was meant to be given for bupivacaine. So again, this problem is not new. And the APSF thinks this is such an important problem that we actually dedicate part of our website so that all of you and our entire global constituency can write into us with these look-alike files so we can post them and send them out via our newsletter, our website, and our social media platforms. So hopefully you don't make those same errors. This is our 3rd conference on medication safety. You've heard that throughout the day. We had one in 2010, and there we actually developed the STPC acronym, which stands for standardization, things that we've talked about ad nauseum today and in previous meetings, technology, identifying medications, training, mandatory safety checklists, pharmacy, collaborating across lines with pharmacy, and standardizing pre-prepared meds, and then enhancing and creating a just culture for all of our hospital systems. But we repeated this in 2018. We talked about drug safety, promoting safer anesthetics for our patients, reducing administration errors, drug shortages. We had a great conversation this morning about it, but we need to simplify ordering and establish contingency plans. And lastly, and very importantly, standardization and innovation collaborate across specialties. It's not just about anesthesia, it's about everybody who works in the perioperative space that we have to get to the table to make change. Well, despite our efforts, and you've heard all and seen all of these newspaper clips, the third leading cause of death in the United States is medical errors. And according to one report, 1 in 10 patients who walk into a hospital are harmed by a medical error. 50% of those are preventable, just unacceptable. Interestingly enough, criminalization of medical error is nothing new. I'm going to spend a few minutes talking about these cases that span over a 30-year period of time. Start in 1990, a nursing home physician in New York accidentally or actually ordered tube feeds to be administered into a peritoneal dialysis catheter, which caused chemical peritonitis and a patient's death after they failed to transfer the patient to the appropriate hospital care. That physician was charged with reckless endangerment. Next case, in 1990, late 1990s, we had 3 Denver nurses who were taking care of a newborn and accidentally gave them a 10-time increased dose of penicillin in the IV space versus intramuscular, which caused that child to die. Unacceptable, reckless homicide. Next case, nurse in Madison, Wisconsin, place that's near and dear to my heart, hooked up an epidural anesthetic with bupivacaine to an IV that resulted in a teenage parturient's death. Again, another unfortunate charge of negligent homicide. And lastly, and sadly, a 2-year-old girl who was undergoing chemotherapy at the time when the pharmacist mixed that chemotherapy in 23.4% saline versus normal saline, which resulted in this child's death. Simply unacceptable, but this is nothing new. However, this is also nothing new to the global community. There are reports throughout the literature and newspaper showing that surgeons, anesthesiologists, other anesthesia professionals, trainees, primary care physicians are charged with jail time, probation, overturned convictions, drop charges, and not guilty verdicts in Japan, Australia, Great Britain, China, and even Canada. So this is a global problem. So what was really the catalyst for a call to action for many of the organizations you represent, including the APSF? Well, it was the case in 2017, and I'm not going to go through all the specifics, but it was a Tennessee nurse who accidentally administered vecuronium when she meant to give Versed or midazolam to a patient that resulted in a patient's death. And if you look at this long list of distractions and errors, if we take 1 or 2 of these out of the list, that patient might have survived, and we might have not had all the catastrophic events that have occurred in this particular case. But that promoted many organizations to start thinking about this, developing position statements and action plans. But I want to remind everybody that criminalization of error has tremendous unintended consequences for healthcare. So we start with criminal charges of a healthcare provider. What does that do? That produces fear of the loss of livelihood for all healthcare professionals. And then it also sends a message that healthcare professionals have to be and should be perfect, which we know none of us in the world are, let alone healthcare professionals. Then what happens is the current healthcare professionals leave the profession. There's increased civil litigation. There are significant shortages of healthcare providers. So now we build upon the COVID pandemic. We have loss of great healthcare professionals, and also promotes defensive medicine and unnecessary testing, which then leads to unsafe conditions and a decrease in healthcare access, all leading to patient harm. So this is not the answer. Well, a lot of the societies that many of us are part of came out against the criminalization of medical error when not intended. And I'm not going to go through all their specific statements because I'm going to turn the page on what we did as the APSF organization. What we did is we got together a multi-professional, multidisciplinary group of folks that included attorneys, CRNAs, anesthesiologists, intensivists, pharmacists, surgeons, patient safety advocates, and patient safety scientists to figure out what we were going to do, what kind of statement we were going to develop with regards to the criminalization of medical error. So we published the position statement in the October 2022 APSF newsletter. And first and foremost, we believe that criminal prosecution provides no comprehensive mechanism for exploring the underlying causes of patient harm. However, we thought it was appropriate to discuss when it's appropriate to prosecute healthcare professionals. Number one, when those professionals engage in a pattern of continuous reckless behavior. Number two, when they commit errors that lead to harm while under the influence of substances that impair their performance. And then number three, when they actually intend to harm. And believe it or not, we all know cases in the literature and in the newspapers of where, unfortunately, healthcare professionals do intend to harm. And by definition, this is not an error. We also wanted to talk about what healthcare organizations should do to mitigate medication errors. Number one, we should employ medication safety techniques that we're all discussing today in technologies. We should operate on the principles of just culture. Again, where every single one of us has a voice at the table to recognize threats and then do something about it so that the next patient does not get harmed. Disclose to the appropriate authorities. Develop a multidisciplinary medication safety committee. I'm going to stop really quick because the last 2018 meeting that I attended to at the APSF, I came home to my own institution and I found out we didn't have a perioperative medication safety committee. So I started one. I started ones with pharmacists, nurses, legal risk managers, pharmacists, everybody you could possibly, surgeons, get us together and figure out what we can do to eliminate or reduce error. And I'm proud to say that today we've developed over 2.5 dozen interventions that have either eliminated medication errors in certain areas or reduced them substantially. And we were just recognized last week from the Magnet survey for being a quality multidisciplinary committee that has actually made change. So that you can actually do these things in your own hospitals and communities, and it's not that difficult. And then ensure compassionate treatment for those that have not only the error, but also the second victim. What should healthcare professionals do? Well, I think it's time. We've always talked about it, but we need to make sure that we look at the dispensing of methods for high-risk drugs. We only should use override methods when urgent and emergent situations arise. And when we do that, we should institute a double verification system. We've done that in our own institution on every single subarachnoid block placement. There are 2 healthcare professionals that have to look at the vial, make sure it's preservative-free, make sure that there's no expiration, and it's the right dose, right patient, and the right concentration. So we really need to work together to do that. We need to ensure appropriate monitoring of patients receiving high alert drugs. We don't need to contribute to normalization of deviance, and we have to empower all of us and others to speak up when we see these threats. So what's the APSF going to do? Well, if this happens to a healthcare professional who did not mean to make an error, we're going to learn about the circumstances. We're going to make public statements about the harm of unreasonable retribution for medical error, reporting to patient safety, and we're actually going to provide information to prosecution about system issues and harm that would be done by prosecuting healthcare professionals who intended no harm and had helpful intent. And then finally, we're going to provide comfort to that healthcare professional. Lastly, the APSF's intention is to foster patient safety by making public statements about efforts by organizations and governments that you all represent to improve patient safety. We're going to make best practices available like we have on the APSF newsletter, our website, and social media. And we're going to inform patients about what questions and what answers we might be able to provide them in terms of safety in the perioperative space. And we recently developed a website in that aspect, and it's actually developed a significant amount of page views. We're working collaboratively with professional organizations and advocacy groups to enhance awareness of medical errors and systems, to identify and implement best solutions. And yes, of course, you are now at our 3rd consensus conference on this medication safety process. So I want to leave you all with this idea. We need to make sustainable change. I heard somebody earlier say we might need to even think about mandating it, but we have the necessary brain power in this room to make a difference, get together, talk across organizations and across individual hospital systems and industry to make the necessary change that will allow our patients to have a safer environment and the providers that also suffer from these type of errors. We're great at spreading knowledge. Now it's the time to work together to make the change at the bedside. I appreciate everybody. Thank you for participating in this great conference.